famous place called Martha's Vineyard. That's the famous holiday resort of people like Bill Clinton and the Kennedy family, you know. So this lady owns the hotel, and the daughter told me that, I don't know why my mother, she knows that thing, you know, that the clock, she forgot the name, clock, it's for telling time, you know. Or when I asked her, what is this? She said, well, I don't know what, but it's for telling time. Nominal dysphasia, you know, names forgotten, but memory is okay. So these are the other signs of Alzheimer's disease, non-memory symptoms. Okay, let's move on. All right. The genetics of Alzheimer's disease and often linked with ApoE, only about 2% of population. You know, people think it runs in the family, only about 2%. Most cases are sporadic Alzheimer's disease. I have somebody in KL who brought the mother to see me for diagnosed with Alzheimer's disease. She wanted a second opinion, and it's a lawyer, you know, a hotshot lawyer in KL. And she said, "Can you see this patient? Can you see my mother?" As I saw her, and I told her I agree. The diagnosis, no doubt, is Alzheimer's disease. And then she began to cry, you know. Then she was very angry, and then so I said, "What happened then?" So I'm very angry because I read in the newspaper that there's a genetic predisposition. My mother has given me this gene, you know. It's not about my own family, my children, you know. So I told her it's only 2%, you know. If you know, most unlikely you'll get it. You know, most patients you see are sporadic. I told her that you've forgotten the mother also gives the gene for intelligence. You're a lawyer, you know, and you're a charming, beautiful woman. You know, you forgot all this. You only remember my mother gave me Alzheimer's disease. Age is a risk factor. Although I mentioned that 65 and above, it's about 3%, but as you grow older, 80 years and above is 12%. The chances goes up. You know. Head injury, hypertension, and Down syndrome. You know, let's move on. You know. All right, these are the plaques and tangles observed by Alzheimer's almost 100 years ago. And the plaques are in fact amyloid plaques, with a lot of cholesterol inside there. These are the plaques will destroy the synapses, and therefore the depletion, especially of acetylcholine. And the tangles are in fact intracellular. They are more twisted helical structures of a tau protein. I'll talk about that later on. Let's press on. Yeah. All right, these are the structures where there are a lot of plaques and tangles, but the temporal lobe here, and also the prefrontal cortex. You know. Let's move on. You know. Okay, is there any neurologists here? None. I'm glad, because every time I give a lecture, the neurologists ask me, "Can you tell us something about dementia with Lewy bodies?" But since there are no neurologists here, it's quite uncommon. But anyone taking exam, they often ask people in exam also. You know. All right. Dementia. The patients will often have hallucination, delusion, and they respond quite well, you know, to medication, and even your rivastigmine or your Exelon. You know. All right, I'll run through the clinical management. It interests all of you. Beside the transmitters and also the behavioral techniques, family support, something about cholesterol and Alzheimer's disease, and proteomics. Let's move on. Okay, we know that in Alzheimer's disease there's the depletion of acetylcholine, the neurotransmitter. And for some of you doing part 1 exam, MRCP, they will ask you which nucleus is the nucleus of Maynard. It is a degenerated, you know. There's the nucleus for acetylcholine. And so we need cholinesterase inhibitors to prevent a depletion. And these are the 3 compounds, you know, rivastigmine, which is Exelon by Novartis, Aricept, and also galantamine. And they're also very useful for vascular dementia. Right? We move on. Right? I'll talk something about rivastigmine because the Novartis sponsor your dinner. Right? It's good for mild and moderate dementia. What about for the pre-senile stage? I mentioned people with executive function problem, mild cognitive impairment. You know, so there's some research being done now, or even we're not too sure about people with severe dementia. But I often give it as a start about 1.5 milligram. I give a starting dose first, and if there's no adverse side effect, commonly it's nausea. You know, the old people will tell you, I feel nauseous, tummy discomfort, I don't take medicine again. But you reassure them that this will disappear in 1 to 2 days. And once there's none of these side effects, I'll increase from 1 tablet in the morning to 1 in the evening. Right? So it's twice a day. And I'll increase to about 3 milligrams twice a day. Right? And the only thing I'm afraid of is sometimes if they have an increase in acetylcholine, you know, the cholinergic effect, then there be a degree of bradycardia, the bowels will go down. So keep a check on it, right? Although they'll tell you in the insert of the box that is also useful for people as high as 6 milligrams. Often give it if they have agitation, you know, or even restlessness. That medicine is quite useful, or people with hallucination. Next one, please. All right. Now, besides acetylcholine, all right, this medicine is quite good because it also increases another neurotransmitter, you know, uracilcholine. You know. Uracilcholine is an interesting neurotransmitter. I remember when we were a medical student, I hope our good friend Dr. Thayaparan will know it, that we don't know exactly what it's all about. It was just mentioned by Professor Chan Kong Yu, and then we stopped, you know, because people don't know the of this medication. Somewhere it's a pharmacist, you know. You tell us anything more about this, the pharmacist? We don't. But this is found also to slow down Alzheimer's disease, and it helps to prevent. It doesn't cure Alzheimer's disease. It prevents a rapid deterioration of the cognitive function, you know, and also it's very helpful to reduce agitation. All right. Something on pharmacogenetics. A group of our researchers. Our team is very, very big. You know, we have about 40 or 50 people, but 20 people are the basic scientists. They are the neurochemists, and they are also the genetic people, and most of them are clinicians. And the group of people are the pharmacologists and also the psychologists. But they found that people in this American study, those who have both the two alleles or ApoE carriers, the genes, they are the worst responders. But people with ApoE3 are the ones who respond well to this product. Right? Next one. Now, I'll give you something very interesting, which is just hot from our computers. We're trying to find out what is the life cause of Alzheimer's disease. I mentioned to you that sometimes a lot of data we have comes from the West. And I told you about our data of 5%, whereas in the West it's about 10%. You know, and remember, even a long time ago, we're taking an exam for MRCP. They asked you what's the prevalence of dementia. You must take 10% is correct. Now you put 10% is wrong. This is 5%. Similarly, also for dementia. When I was a trainee, I was told that if you diagnose dementia, the patient would die in 5 years. You know, but this is not found to be true from our own study. We have two groups of patients. You know, for last these are patients given before the medicines come to Singapore. Maybe about 15 years ago. That you find that the life course of patients with Alzheimer's disease is about 8 years. The first phase are very mild, moderate, and severe. Right? These are all true. Now, after the advent of these cognitive agents, besides Exelon, also Aricept, now the mild phase is a bit longer now, you know, and moderate phase also a bit longer. The severe phase is about the same. So the medication has prolonged the life of the patient, and also the quality of life is more important. It's not just prolonging the life. If you prolong the severe phase, I don't think it's much the relevance to the patient. You know, it's the quality of life in the mild phase and the severe phase. Okay, now other people are very interested. Yesterday someone was asking me about various kind of antioxidants. We know that in Alzheimer's disease and in aging, there's the free radicals. The free radical destroys the tissues in the body, and you have, and these are because of oxidation, you know. But you have antioxidants that will reduce the breakdown of these cells, and these are some of the antioxidants, and vitamin E, B12, and vitamin C. So in Harvard, everybody comes to the clinic will be given vitamin E. You know. But later on, about a year ago, results show that there's no difference. You know. Even all the doctors there also on vitamin E. I was the only one without vitamin E. I didn't believe it. But now the research came out from Sweden that there's no protective benefit. You know. Now ginkgo biloba also a very strong antioxidant. And this paper published in New England Journal of Medicine, one is useful for early dementia, not for the late dementia. Then green tea, we're doing some study in green tea. This study is done also in UCLA about berries and grapes. I'll talk about turmeric, cumin later on, and omega-3 fats mainly in fish. And so these are things you can tell the patients and to help them out in kind of food.